Hello, welcome to EASL Studio, your weekly hepatology broadcast news. In today's episode, we will tackle and discuss the implementation of the EASL MASLD clinical practice guideline that was issued last year. My name is Sven Francque. I'm a hepatologist at University Hospital of Antwerp in Belgium. And as you can see, I have three colleagues here with me who I will let introduce themselves a little bit later on, because first I would like to introduce a little bit the topic of today's discussion. As you know, in 2023, we changed the nomenclature of NAFLD. We introduced, first of all, the umbrella term of steatotic liver disease, which is important, I think, because it brings together all the different causes of steatosis. And of course, the most important ones are metabolic risk factors or cardiometabolic risk factors and alcohol, or the combination of both. The other change with the nomenclature was the introduction of the term metabolic dysfunction-associated steatotic liver disease as the replacement term for non-alcoholic fatty liver disease. Now, I don't need to tell you that we are facing a huge challenge here in terms of numbers of patients that we need to manage, and also the issue of awareness and underdiagnosis is, of course, a crucial problem. Now, last year, EASL issued a new clinical practice guideline for metabolic dysfunction-associated steatotic liver disease. And we did not do that on our own. We did it in collaboration with the European Association for the Study of Diabetes and the European Association for the Study of Obesity, really emphasizing the fact that this is a multi-system disease that needs a multidisciplinary approach. By the way, also the previous EASL clinical practice guideline in 2016 was already with those two societies. So we were at the forefront of making this multidisciplinary approach. So it's really teamwork. And that is something that we will discuss during this studio. It's also important to highlight that EASL has taken the initiative of building an educational implementation program around the clinical practice guidelines. Clinical practice guidelines are leading clinical practice worldwide, but it's not an easy process to write them, but it's even more difficult to make sure that they are picked up and implemented in clinical practice. So this studio is also part of the implementation program of that new MASLD CPG. But without further ado, I would like now to invite my three colleagues to introduce themselves. And Shelley, perhaps you can start.
Yeah, sure. It's really lovely to be here. So my name's Shelley Keating. I'm an exercise physiologist and researcher from the University of Queensland. And my area of research is really centred on the role of exercise in the management of MASLD. And ultimately, the goal is to increase the access, awareness and priority of exercise for the management of MASLD.
Thank you, Elena.
Hi, lovely to be here. Thanks for having me. So I am a researcher and a dietitian from Deakin University in Australia, and my research is around lifestyle and in particular diet for MASLD, and I'm very interested in the practical changes that we can make for behaviour change, and in particular social and cultural adaptations to make sure that behaviour change is easy for everybody.
Thank you, Elena. And Marta?
Hi, thanks for having me. So I'm Marta, I'm a nurse and I work in Hospital Clinic in Barcelona. I combine research with clinical care in the hepatology ward. And what I'm doing in my research work in a nurse field is to investigate in lifestyle changes in patients with MASLD.
Thank you. And as I said previously, this is not about just an antiviral treatment for a viral disease and an interaction between the patient and the treating physician. This is way more complex and really needs teamwork. And learning also from the experience in my own center and my own country, where it was not that easy to build that kind of multidisciplinary approach in clinical practice. I would like to know from the three of you how it's going on in your center, your region, your country. How are these things organized or not organized yet? Marta, perhaps you can
Okay.
start how it is in Barcelona.
So in our center, all the patients, the 80% of the patients are referred from primary care. So we have the hepatology has a specialized MASLD consultation, but the hepatologists have only 15 minutes per patient, so which is very little time to perform lifestyle education. We do not have established an advanced practice nurse for specialized in MASLD. So the patients that are obese, they are referred to the obesity clinics, which is in the proper, in our hospital. But the patients that have type 2 diabetes, they are followed at primary care. So this connection is challenging. This link into these two different levels of care is challenging. And also we don't have a dietist in our team. So only the patients that have obesity can go with the dietist. Otherwise, also the patients that are not obese, that are normal weight or overweight, they have to do these lifestyle interventions in primary care. But based on EASL recommendations, we started a pilot program with a structured lifestyle intervention with the aim to in the future establish a multidisciplinary team and a multidisciplinary MASLD clinic.
Okay, very interesting. And also you picked up EASL guidelines, so that's very good. Elena, how is it in your center?
I was going to say, so similar to what Marta was saying, it's not a given that there are dietitians or exercise physiotherapists in the clinic in Australia. So there are some services that have started offering more allied health services. The majority would go through primary care, but there is a screening for MASLD routinely in primary care, and those that are referred to the specialist services, the services are mainly reserved for those that have more progressive disease. So if you only have simple steatosis, you're likely to get discharged. And I guess it's a lost opportunity because we want to target people at the earliest stages so that we can prevent not only the progression of liver disease, but also the progression to other comorbidities like type 2 diabetes if they haven't already, if they're not already experiencing this. So we need, as you said, Marta, we need more sort of multidisciplinary services, but there is even more work to be done at the primary care level to identify the patients in the first place, and then, to be able to offer services for them that are allied health services. And I think lifestyle is the cornerstone. That's where we need to start with everyone. So we need very accessible behavior change strategies.
Shelley, how is it in your center? Along the
Yeah,
same line, or?
Yeah, so I mean, Australia's obviously quite a large country, and Elena and I are from different states, but there are similarities, across the board. I think in terms of, the management of diabetes and the management of obesity and the management of MASLD, traditionally it has been quite siloed, so there hasn't been a lot of linking and crossover. But again, with the global movement to increase awareness of MASLD, there is a little bit more interconnection between those types of services. But as Elena mentioned, a lot of it is centered in primary care. And I think, in terms of ultimately managing the very high numbers of people living with MASLD, whether knowingly or unknowingly, we do need to increase awareness and screening at that point. I think there's going to be a need for more resources and, Medicare items and whatnot available for that to happen. We do have an example in our area of an integrated care clinic where patients living with MASLD are referred and get access. So it's there's a GP within the centre, it's a tertiary centre, and they have access to a psychologist, a dietitian, and an exercise physiologist. So it's a really unique centre. It's a sort of one-stop shop for lifestyle and behavioural change care. The challenge there, as always, is it's a small program. I think it's about 12 weeks. And there's lack of continuity of care into the community. And I think that's probably, in terms of managing MASLD long-term and promoting sustainable long-term lifestyle change that is culturally responsive, we need to have much better point of care tools and also really strong links with community service, so allied health professionals in particular. So there's a continuity of care for sustainable care.
So what I hear a little bit across all our interventions is that there's still a lot of working in silos, as you say, obesity clinic, diabetology clinic, general practitioner, hepatology clinic, but the example that you're highlighting, Shelley, about an integrated, could I call it a kind of metabolic health program rather than a specific MASLD or diabetes or obesity program, or is that a little bit too far?
At this stage, it is centered on MASLD. So they've gone through the hepatology clinics and have been referred to that pathway. So it is specifically targeting that. I'm sure many people, attending that clinic also are living with obesity and, managing type 2 diabetes. So I guess there's certainly scope to have these types of clinics more broadly. In Australia, we do have slightly different Medicare service opportunities for people living with type 2 diabetes. So people with type 2 diabetes, they have our standard 5 allied health visits per year that are covered by Medicare, which is our universal sort of healthcare program. And people with type 2 diabetes also have access to 10 additional group-based sessions that could be run by a dietitian or a diabetes educator or a exercise professional. So, one of our goals is that hopefully those items can be broadened to people living with MASLD and obesity more general, so a bit more opportunity for rebatable healthcare per calendar year.
Mm-hmm. Yeah, because indeed one of the problems I also experienced in my center when we wanted to create a more multidisciplinary approach is that there is very little reimbursement for that. The system is investing a lot of money in drugs, in consultation of the physicians, in diagnostic, more end-stage disease curative care. But there's very little investment in early intervention with different healthcare practitioners that need to be involved, with the exception, as you say, for diabetes. That's also there is more reimbursement there, but outside that, obesity medication is not reimbursed. I don't know, Marta, is that the same in Spain? Is that also a hurdle to make step forwards?
Is the same in Spain. Yes, there is not exist a guideline of managing liver diseases in primary care. So there is a lack of awareness in a lot of professionals that works in primary care, which are those that could do the prevention or the promotion of liver health. So this is something really challenging for us.
And you are also part of the EASL Nurse Task Force. How do you see the role of nurses and also the differences across Europe in terms of specialized nurses? I mean, for diabetology clinics, probably there is a little bit more progress made over the last years, but it's my impression that in general this is still not well used, that capacity and that potential and expertise.
Yeah. In fact, it's very heterogeneous across Europe. In some countries, like in UK or in Netherlands, the advanced practice nurses are well established. They have well established roles and are well recognized. But in many other countries in Europe, for example, in Spain, the role is less defined and is not yet recognized. So there is a strong need for this recognition and also I think that super specializations like the advanced practice nurse in MASLD is a growing need, and it's a good thing to have these super specializations, because because this can the expertise of these nurses can bring very valuable expertise in the multidisciplinary teams. So we have advanced practice nurse for hepatocellular carcinoma, for viral hepatitis, or for pre and post transplant, and for those patients that have decompensated cirrhosis, but we need another one for MASLD patients.
Mm-hmm. So still a long way to go. Shelley, Elena,
Yeah.
who is driving the multidisciplinary approaches in your country? Is it also with an important role for a specialized nurse, or who is there the driving force?
Yeah, I think that there is certainly a role. So the nurses have, I guess, a lot of time, I guess a lot more time with the patients. So it's probably a really important role to increase, I guess, more broadly, lifestyle recommendation awareness, that from the practice guidelines, so that they could be a first point of education and awareness around those specific aspects of care. So they do play a really central role, and ultimately would also play a role in referral to community practice. So referring to dietitians, referring to exercise professionals.
Yeah, I would agree. And I think in particular, there's an important role in regional, rural, and remote communities. So people that opportunistically might see someone in primary care, if there was an advanced sort of educated nurse that can start to talk to them about allied health and behavior change, it would give those individuals an opportunity to start understanding their condition and behavior change and getting access to some care when they're probably not going to have access to any other allied health professionals in any other way, because they're either not present, or it takes them a long time to travel there, and the cost associated with that as well.
And in terms of gaps in knowledge and training, I'm not talking about awareness in population or the patients, but amongst us and allied healthcare professionals. Where do you identify gaps in knowledge and education that we might help tackling?
I think from a nutrition perspective, I don't think there's a lot of upskilling nurses to understand the benefits of diet. I think they understand this at a broader level, but having a deeper understanding would help implementation in practice. So even at the education level as well, like when they're doing their initial degrees, raising that awareness, and then having there isn't anything like what Marta described in terms of an advanced nurse practitioner or any education for MASLD specifically, which would work well given how many people could benefit from that care.
Yeah, and I'll add to that in terms of people who are trained to be exercise physiologists in Australia, so it's something that we're trying to work to elevate MASLD in the curriculum. So we did recently write Exercise and Sports Science Australia, which is the professional body for exercise physiologists in Australia, a position statement around exercise and MASLD, and we're now trying to bring that into the university level training. So increasing the awareness of the allied health professionals of the condition, as well as obviously increasing the awareness of the recommendations for exercise and the practical points regarding sustainable, accessible exercise care at the nurse and the sort of the medical level. So it's sort of that double-sided approach to education. So that's something that I think can continue to grow. And I do also think in terms of a research gap, we do need to actually do a lot more work in implementation science. So actually using proper implementation science methodologies to understand models of care that are cost effective, culturally responsive and sustainable. So I think there can be a lot more research and work done in that space.
Mm-hmm. Yeah, and that's indeed the research area on its own. It's not that easy to. Sometimes we run some surveys and we think we have already done something, but that's not a professional implementation science. Marta, did you have any suggestions also in terms of gaps of knowledge or education?
Yeah, I agree with all of you. And then I think that regarding the nurses, they should be skilled in motivational interview, and also in the management of all the comorbid.
Yeah, your connection was a little bit unstable, Marta, but I think you're back with us. That's great. So yeah, what I hear is indeed that also having it incorporated in the different curricula will probably be a very important step forwards, and then it's in the training of the youngest generation. So that's in the end the best insurance for the future. That's for sure. Any suggestions how a scientific society like EASL with its different committees and task forces and working groups can help? I mean, as I said, we have been writing that MASLD guideline with the input of several of you, tackling all those aspects. We have the guidelines app, so you can easily get access to the guidelines in your pocket in daily practice. We have the implementation program, including this studio. Hopefully it also will help to create awareness. But how can we, let's say, more practically and make sure that we really have some impact on the field? How could a scientific society like EASL be of help there?
One thing I'll add is I guess there's the new EASL Advocacy Network, Global Advocacy Network, which was launched just recently at the recent meeting, and I think that has a lot of potential to for practitioners and also researchers to hopefully upskill a little bit in advocacy, so we can be individual advocates as well, so sort of contribute toward the EASL movement and global advocacy. I think that will be a really, I mean, it's new, but I think that will be a really beneficial network to be part of. So that's sort of something that's really fantastic to see. I think obviously there's a big journey ahead and increasing awareness, and then sustainable care for people with MASLD, given the numbers and the burden in community. So I guess it's just promoting lifestyle care. I think obviously there's some really exciting movement in the pharmacotherapies, and the potentials of the incretin-based therapies obviously being formally approved in MASLD care. I think really highlighting in the practical implementation of the guidelines to have a genuine co-prescription of diet and exercise along with those therapies. So I think lifestyle care is supposed to be a cornerstone of care across, whether people are receiving medications or not, but to, ensure that patients on these medications are doing exercise resistance training to support body composition, healthy body composition, and seeing a dietitian to make sure that they're, having the appropriate nutritional care. I think those types of things of, genuinely elevating the co-prescription of lifestyle care with pharmacotherapies will be beneficial.
Yeah, I would agree. And I think to successfully continue to achieve that, we need to continue to research the practical elements. So, we have a guideline saying that you need to follow a hypocaloric diet or follow a Mediterranean diet. But I think it's really helpful for practitioners to know, how do you actually educate? What are the effective ways to achieve behavior change? How often do we need to see people? So continuing to research in the space to understand how we can make things accessible for individuals. So when you're seeing a patient, I even get practitioners often asking me, how do you actually practically implement this? What is the tangible advice? And I think we need to be very pragmatic in that people have limited time. So we need to have very convenient solutions. We can't give them complex, changes. We need to give them bite-sized changes over time. We need to work with them in terms of their social situations, in terms of their cultural situations. And I think we need to continue the research in that space to understand how to better achieve that.
Yeah, regarding this line, that's why I said that I think that we have to increase the awareness in nurses, for example, in motivational interview, and because nurses can help patients to set realistic goals. And also another thing that could be very practical is to provide practical resources like patient education material ready to use in different languages, or checklists for clinical visits, or templates for lifestyle intervention programs. So material ready to use could be something practical.
Mm-hmm. Yeah, and I must say that I really like how you are all pointing towards important areas of research. You're not always thinking about it, but indeed, research among in terms of behavioral changes is still a domain where there's a lot to learn. Implementation science, as you say, Shelley. So a lot of knowledge gaps identified. So a lot of work ahead, along with all the education that we need to do, and hopefully improve the level of management by really coming to teamwork in the future, and break the silos that are still there too much for the moment. Thank you very much. This already brings us to the end of this very interesting discussion. Thank you very much. I would like to remember the audience that we have our studio again next week. We'll be on how we can work with the expanding armamentarium for treatment of hepatitis B, and we will discuss this with patients. So be there also next week, same time, same channel. And for this, I would like to thank you for joining us. I thank again my three colleagues for joining this discussion, and especially Shelley and Elena, who also, for you, it's in the midst of the night. So much appreciated to be with us. And Marta, also, thank you very much for your contribution. And see you soon. Enjoy the rest of the day. Bye-bye.
Thank you.